A very good evening, colleagues. A very warm welcome to another weekly Wednesday session hosted by Infectious campus. My name is Obage Mwatse. I serve as the general manager of the Infectious campus group, skills development and training entity that's based in 5 countries, namely South Africa, Botswana, Namibia, Zimbabwe, and Eswatini, with 8 campuses across those territories. A couple of housekeeping requirements before we proceed with our session this evening. Please refer to the chat. In the chat, there is a link wherein you can complete your attendance details. Please be as accurate as possible when completing your details, as this will enable us to circulate the certificate once the session has been concluded. Also, please bear in mind that the session is intended to be an interactive session. However, if you can please remain muted throughout the session, raise your hand to be recognized to make a comment or query. Alternatively, please make use of the chat functionality to type out your question or query, and a member of the team will recognize you. So whilst we're doing the housekeeping, and just a repetition of that is just to say, please, colleagues, remain muted throughout the session. Okay. This evening's session is titled Deep Vein Thrombosis Prevention. The session is going to be led largely by Dr. Jackie Stone, with a featured member of the panelist being Aneri de Vet, with whom Dr. Stone will introduce. If I can introduce Dr. Jacqueline Stone. Dr. Stone is a Zimbabwean primary care physician who grew up in Zimbabwe. She graduated from the University of Cape Town cum laude in 1989. She went on to get a Medical Research Council scholarship to do an honors degree in Medical Biochemistry. From there, she went to the UK and worked in the Infection and Immunity Department of St. Bartholomew's Hospital in London, and wrote her MRCP in 1996. Her main interest was in HIV, and during this time, she was involved with the introduction of combination antiviral therapy as the cornerstone of successful treatment and prevention of the HIV pandemic. She then moved to the Middle East and worked in the airline industry for 12 years. In 2003, she was part of the Airline's SARS-1 task force. She completed a Diploma in Aviation Medicine in 2008 from the King's College in London. This, she feels, taught her a great deal with risk-benefit assessment, hypoxia, infectious disease treatment, and prevention and vaccination. She also became an inaugural member of the Australasian College of Aerospace Medicine in 2012. Both in the Middle East and Australia, she developed an interest in integrative medicine. Good evening, Dr. Jackie Stone.
Thank you, Obi, for that introduction. In respect to the airline industry, I think that we certainly explored DVT in long-haul flying extensively in probably the 2000s to 2003. So that's another reason why I'm interested in DVT, including the last 3 years where we've seen a lot of thrombosis associated with COVID-19 infections. So without further ado, I'd like to introduce Aneri de Vet. Aneri was with us last week in Harare when we were training anesthetists and anesthetic nurses how to scan. with the U image. Annery is an ultrasound specialist. She has worked for General Electric and for Philips and is now involved in the U image, which is focusing on African solutions for African problems. But Annery is much more interesting in her history and how she got to be an ultrasound specialist. And I think anybody in primary care on this call will identify with at least one of the parts of the story. Now, we pre-recorded this last week because we were in the same place at the same time. And in addition, I wasn't sure whether I was going to get back. I've just come back from Lusaka from the primary health conference. And I wasn't that confident that I would get through the airport, but I've managed to get in about an hour ago. So with no further ado, I'd like to ask Pride to play the recording. If there are any glitches with it, we will go back because we can just simply run the session live again. So Pride, please go ahead and play the recording. At the end of it, Annery and I will be available for questions. Good evening, everyone. Welcome to another evening with the Infectious Campus. Tonight, we are very privileged to have with us Annery de Wet. We're going to be talking about DVT prevention. And Annery has a very interesting story as to how she got so involved with ultrasound. So I'd like her to introduce herself and give us a bit of background as to how she has become so passionate about ultrasound. So Annery, over to you.
Thank you, Dr. Jackie. My name is Annery de Wet. I am an ultrasound specialist. I've been involved in ultrasound in different ways, from clinical diagnostic ultrasound to application training to running different ultrasound businesses over the years for large multinational companies. And it started because I had my first DVT at the age of 18 when I was freshly out of high school. And I had a contraceptive medication to try and calm down some of the teenage acne, and had a very swollen leg and painful leg just after New Year's, actually. I remember the GP saying, "Oh, you must have had a nice New Year's Eve party. Why are you limping?" But I mean, I laugh about it now, but back then he just treated it with anti-inflammatories, and my leg proceeded to swell and painful, red, and eventually I couldn't breathe properly. I was using all the pillows in the household to prop myself up to try and just stay up straight, because the slightest recline would feel like daggers, piercing your lungs. It was very, very painful. And yeah, thank goodness my dad especially lost the patience with the GP and took us to a specialist in Pretoria, who immediately saw the signs and admitted me to ICU and proceeded to treat me with anticoagulants and took care of me from there.
Okay, and you missed your first year of university?
So I missed my first year of university, but the silver lining out of that was that I changed course completely and ended up studying clinical technology, which is what I've basically spent my whole life on then, was the business of ultrasound to some degree, whether it's with cardiology clinically or marketing and business management.
Okay. So you were a year on anticoagulants and then they took you off.
Yeah.
And then you were fine for a while. And then can you talk us through your first pregnancy?
Yes, quite a while. I was fine for quite a while. Then I fell pregnant in 2007. And that's the time they diagnosed the factor V laden. Before then, it was just known as protein C deficiency.
Or insensitivity.
Insensitivity, something like that, yeah. But protein C something. And then when I was about 7 months pregnant, I went to my obstetrician to say that I have a very strange burning sensation in my leg. Again, it feels heavy. Something's not right. I'm convinced of it. He knows my history of having that one DVT episode, but he just prescribed a commercially, go to pharmacy and go buy some compression stockings. which to me was not acceptable.
Would you have been able to compression stocking on?
Not at that stage. No, my leg it's painful to the touch. It's very swollen. So no.
And obviously, you at this stage knew every cardiologist and every specialist in town.
Fortunately, because of my work, yes.
So you ended up with a hematologist, and the other specialist was?
Yes, the obstetrician, Professor Godozi and Professor Biochemistry. So I'm happy to say their names. They've been very supportive and helpful. But so from 7 months on, they treated me. Barry Jacobson was the hematologist, trying to keep me as anticoagulated as possible. And the obstetrician wanted me to be as safe as possible on an elective C-section table, so not to bleed too much.
Yeah. So 2 months of enoxaparin injections?
That's right.
What was that like?
It's not pleasant. I mean, injecting yourself, I think I was on twice a day at some stage. And then I think for 6 weeks post-surgeries also. And then from there, we moved over to warfarin again for 6 months or so.
And the other thing I found interesting about your history was you talk about the PI in the baby, because there's a, I wonder if your factor V laden didn't lead to placental issues.
Yes.
So talk us through what I mean, it must have been a nightmare having someone skilled in ultrasound as a patient.
It is always difficult, but I'm not the most skilled in obstetrics, but yeah, there was the need to, especially the last 2 weeks of my pregnancy, every day we did a pulse fertility index and resistive index. And it became clear that my daughter wasn't gaining weight anymore. So she was a very lightweight, like 2.1 kilograms at birth. So they decided to do the C-section a little earlier because she was clearly not gaining weight. So there's definitely some complications from either the anticoagulation or the factor V or something.
Okay, and then
finally found the golden midway and had a very clear guideline of when you take your last half a dose the night before. We'll do your first case of the day early in the morning, and then you'll be done. So the C-section went relatively okay, I think, but it was definitely very painful for me. In recovery, I experienced quite a lot of pain. I think the anti-inflammatory pain management was skimped on because of my condition, so that was very, very painful.
And probably they did a lot of cautery, because when you've got a patient bleeding, they cauterize a lot, and that, from my own experience, is exceedingly painful.
That can contribute, yes.
So after that, did you go on to warfarin, or?
So I was on warfarin for about 6 months or so, yes, and then there was no need to further continue, and we just weaned off it again.
Okay. And then you got pregnant with your son.
So against some medical advice, I did have a second pregnancy. I got pregnant with my son. And now being very keenly aware of the 2 DVTs I had, I suffered from severe morning sickness with both pregnancies, but the second time around was particularly severe. So I was extensively dehydrated, I think. And at 14 weeks, I felt again that very familiar pain in my left leg, and I just knew there was another clot. So fortunately, this time I already just went straight to the hematologist, who then at least took me seriously, unlike the previous 2 occasions. So he then just also said that it was against his protocol for prophylactic treatment, started 18 weeks, and here I am at 14 weeks and already with confirmed DVT, and him and the obstetrician proceeded to manage for the rest of that pregnancy, which was probably, in retrospect, went much better, obviously, than the first one, even though I clotted way sooner, and even the pain management was improved. So I think it wasn't nearly as uncomfortable as the first time around. So second one, and for some reason, my son weighs a hefty 3.7 kilograms, so he did well.
Okay. And then how long were you anticoagulated for after you delivered?
Again, this third one was, third DVT was just for another 6 months or so, and then we moved it again. So that I thought was the end. There's no more babies, no more hormonal treatments or anything. So that was the end of my DVTs. So I thought.
Okay, and then?
Then this was in 2010 when I had my son, and then in 2012 I had attended an obstetrics conference in the Drakensberg. It's about 4 hours drive from Johannesburg, and I woke up that night with and I don't know if it's because of the driving or the long, being sedentary a little bit. I had that burning sensation again, and quickly confirmed it with the transvaginal probe. It's all we had available at the moment at the conference. But at least I was able to quickly, kind of point of care, just quickly confirm that there was indeed a blood clot, which was extremely distressing to me because it was out of the blue. We don't know why it was. I couldn't understand why I'm not pregnant. I didn't do anything wrong, as I thought. So yeah, that was very distressing. The spontaneous DVT. Drove all the way back to Joburg and went to a vascular surgeon who admitted me to hospital just to treat me, and then back to my conservative treatment path that they followed was just to say stay on anticoagulants for a longer time, maybe for a year this time. And this particular blood clot, also on ultrasound, looked very sinister. It was quite amazing to see. It wasn't a plaque like I've had before. It was a long serpent-like with a little stem attached. So it was like drifting along the stream type of. It felt like the slightest sneeze would dislodge it. So it was psychologically you're too scared to move. You just stay still and hope it dissolves in time, which also thank goodness it did.
Okay, and things like graduated compression stockings, intermittent pneumatic compression.
Yes, that was the time I was in hospital. They did use the compression, intermittent compression machine, and also having to wear the stockings, which definitely, I mean, even till today, I wear them when I travel long haul because my feet swell a lot, and that's the only thing that prevents my feet from swelling. So I do like the comfort that it gives me if you don't have an active DVT, which can be quite painful to put on. But normally I wear the stockings. It's sometimes a bit harder in the middle of summer, I have to admit. But yeah, long haul, I wear them.
Okay. And did you remain on anticoagulants?
I did not. There was no need again to do that until.
It depends which protocol you read. Yeah.
Yeah, that's the guidance you follow. And then until my last and most recent DVT was in 2019. I called 2019 my DVT year and 2020 is the COVID year, right? So 2019, I was admittedly working a lot. I was in front of my computer, so seated, and I think there's a psychological thing. If you're a well-informed patient and you are vocal, advocating for your health when you know there's something wrong, and then still not to be listened to is very upsetting. So I was first a little bit in denial, but over a few days it got so bad that I couldn't walk anymore, and I had to read the writing on the wall. I went to a local ultrasound radiologist who had an ultrasound. He did a quick scan and said, not to worry, there's no DVT, you may go home. So I went home, and in a lot of distress, my leg is painful, I can't walk properly, and I confirmed my own DVT myself with a point of care ultrasound device, and I could see that there was definitely DVT. That was on Valentine's Day, the 14th of February. So on the 15th of February, I was admitted to hospital where the ultrasound exam was repeated. He thought it was an additional scan. That's a different topic on how we bill for our patients. But and it was clear that the DVT has now basically was 99% occluding my femoral vein. Massive DVT into the iliac vein and needed immediate treatment. I had a lung CT done as well, pulmonary embolisms, bilateral saddle embolism confirmed. So that was by far the most severe one, and in my books also the most upsetting one. If a patient comes with a history, known factor 5 Leiden, and 4 previous DVTs, you scan until you find it, and it wasn't even hard to find.
And part of the reason was because protocols said that you didn't scan above the groin, is that correct?
one of the reasons was that the DVT originated maybe in the iliac, yes, and that it would have meant from scanning from the groin down, you didn't see it, but the slightest angle up, you would have found it. But that's groin ultrasound, that's not lower extremity ultrasound. So I'm also advocating for a change in protocol in that regard.
Given that you've recently flown in from Durban, please tell me you're anticoagulated.
I am anticoagulated at the moment.
Right, so I'm going to share my screen, and we're going to have a look at DVT prevention. So I'm going to start the slideshow from the beginning. And we're going to discuss DVT prevention, but I'd like to go through it with you because you haven't seen this presentation before. And the first thing we talk about is Virchow's triad. This goes back to the 1850s, where they described hypercoagulability, which you clearly have. Just out of interest, have you checked your children for it?
I have checked my daughter because she is 16 now for the factor V Leiden specifically, and she tested negative.
Yeah.
So, yeah, especially all the hormonal things happening, I think that is a good thing. I don't know if I should test my son as well. No,
And I would read it for peace of mind, really. But if you've got stasis, which you've described, also, obviously, if there is occlusion to venous drainage with a fetus or a baby in the pelvis, that's going to be a problem. Pregnancy increases hypercoagulability. And very importantly, with factor V Leiden, there is a 30-fold increase in DVT. If you have, we know that now, they may not have known it at the time, but if you start someone on the oral contraceptive pill and they take oral estrogens, there's a 30-fold increase in DVT. And what is also interesting, the same applies to pregnancy. And if you are of Northern European heritage genetically, 1 in 25 of us carry factor V Leiden. So I think it's a very important thing. I know that there are GPs in Harare who do not start the oral contraceptive pill in someone who is Caucasian of Northern European origin without checking a factor V Leiden first. But again, that GP had to nearly lose a patient in order to be aware that this is a real risk. And we've often spoken about Serena Williams. You said that one of your GPs said, what are the chances?
Yeah, when I was the very first one, because I wasn't getting better, and he just said once come forward. I remember it so clearly.
And again, what are the odds with Serena Williams? And the answer is a 1 in 250, actually. So for those of us that are Northern European heritage, it's a problem. So let's look at venous thromboembolism in Africa. And the important thing is the last line. Well, it's one of the 3 main causes of cardiovascular disease worldwide. And the prevalence of VT in Africa is high following surgery, in pregnancy, and postpartum. And at least 1/4 of patients at risk of VTE in Africa are not receiving prophylaxis. And it sounds like 4 times you didn't receive adequate prophylaxis. So it's a common complication post-surgery. And according to a review published in the Journal of Thrombosis and Hemostasis, the prevalence following surgery in Africa varies between 2.4% and almost 10%. So that's a very high number. And when you go deeper into the paper, you will see that the more educated the doctors are, the less the risk of DVT. So pregnancy and postpartum, on average, 1 in 250 women who give birth will get a DVT.
Yeah.
And that's something that it makes it worthwhile in an obstetric unit being able to do point of care ultrasound. What I also wanted to ask you is, you were at a conference, okay? And it was obviously a gynae conference with lots of curvy linear probes. Just talk briefly through how point of care ultrasound needs a linear probe and why.
Yeah, because you need the resolution and you need do not necessarily need a lot of penetration because of the groin area or popliteal behind the knee is sufficient for a linear probe to get the images you need, right? So the gynae conference it's kind of
gynae.
No, they don't use it. They should, I think. Some I mean the fetal medicine specialists might have a linear probe because of the really high resolution imaging you can get, but you're very limited in what you can see from a fetal perspective. But it is definitely needed for DVT screening for sure. I found it, looking for myself, it's not difficult to spot. I think the intimidation factor shouldn't be there to screen for DVT. It's a pretty
nurses, you've been training nurses to do fetal medicine, fetal sonography, so there's no reason that anybody can't pick up a DVT, and we can't train nurses on an orthopedic ward, for example, to do pulse, blood pressure, quick DVT screen. One of the gynaes recently also said that you can't see the breast tissue, and very often people who are postmenopausal will go to their gynae for a well-woman check and then say, oh, by the way, I think I might have a breast bump. So what would be best to look at a breast bump?
Also a linear probe. So the linear probe is definitely the preferred method to look at breast tissue. Naturally, if you have very large breasts, the penetration can sometimes fall short, but that's just a limitation of the ultrasound physics across all products, right? So you need to maybe then switch to a linear, but breast is definitely, linear is definitely the best probe for breast imaging. But of course, we are not saying that ultrasound is the only way to image a breast. You still have your mammography as the gold standard. But if you have dense breast tissue, and you don't necessarily know if you have dense breast tissue, there are many reasons for you to have a supplementary or a screening ultrasound in order to get to the mammogram or to the right.
Okay, and I think in general, I mean, when I first started using this, it's like, somebody, can you please teach me how to turn this thing on? And then, but what you need is pattern recognition. So if you were a GP or a gynae and someone presented with a breast mass, all you really need to know is whether it's cystic or solid, because that determines the urgency of the referral. Would you agree with that?
Yes, and you can see it if it's cystic.
So you don't need to measure it, you just need to recognize the pattern. Cystic is black.
Solid is white.
Solid is white. If it's solid, urgent referral to.
And that's the idea. It's the referral pathways that enable the screening to such a degree, because obviously there's lots of other nuances to it once you get to the referral place. But from a screening perspective, you're absolutely spot on.
Okay. So I think that's a really important thing to note. And talk about having a saddle embolus. If you'd had a saddle embolus in the Drakensberg, what would have been your probability of surviving?
Well, between the Drakensberg and the driving myself back to Joburg, which in retrospect was not the smartest thing to do.
You're probably hypoxic.
Yeah, and at risk of having another embolism. So yeah, I think it's just my guardian angels must have been working overtime during that period.
I agree. So the important thing is, if you have a PE in Africa, it's got a mortality rate of 40 to 70%, basically. And we need to be very, very aware that obviously every DVT doesn't lead to a PE, but if it does happen, the risk is very high. So we know that if we look at hospitalized patients, because it's not just orthopedics and surgery, it's medical patients in cardiac failure, in CCU or ICU, and they are immobile for 5 to 7 days. We know that, let's just take it so that it's easy to remember, 50% were at risk for venous thromboembolism and only 50% received prophylaxis. So we really do need to up our game in Africa. So one of the things we've been talking about is the direct oral anticoagulants, which is the rivaroxabans and the other similarly named agents. And we know that it's been hampered mainly by their higher acquisition costs. Certainly when we were using a lot of anticoagulation
in the 2020 year, the generic form is rivaroxaban, but its trade name is Xarelto, and patients were paying over $100 for 30 tablets, which is just unaffordable if you are prophylaxing with it. So I'm going to skip over this, but this is a case presentation of a 61-year-old male who is overweight, has a family history of DVT. His grandmother died at age 69, who's due for a total knee replacement. This is a real case. This patient received probably a week of enoxaparin. He had a couple of jab, the night before theatre, because it works immediately. And then it was continued for a few days after, and he left. So, but let's put, if we look at him, he's going for a knee replacement. He straight away scores 5 because he's having elective major lower extremity arthroplasty. Now, I presented this at the orthopedics conference. I'm now presenting this to primary care doctors because the orthopods and the surgeons are focused on surgery. They don't focus, and they're not really, I don't expect them to be necessarily interested in this. And they also don't see the DVT and the PE because the patient is discharged and presents to their primary care doctor and is then referred to a physician. Or, as Tina had said, how many of them die post-surgery, and you never know because there's no way of getting back to the surgeon. So step 1, you have, when we look at the questionnaire, we look at risk factors associated with clinical setting. So a medical patient who is on bed rest or who's had minor surgery would get 1. If you've had major surgery, if you've been immobilized in the plaster pass, if you've had arthroscopy, you score 2. If you've got major surgery that's happened, so for example, as we were discussing earlier, with one of the cardiothoracic anesthetists, what if you've had a myocardial infarction and you are now going for open heart surgery and you've just had open heart surgery? You would be basically scoring 3 there. And then if we look at the scoring of 5, in this country, we have so much multiple trauma. You've recently been in an emergency conference where they discuss multiple trauma. So if you've had a hip replacement, a knee replacement, or if your patient is going to have one of those, if they've got a fracture in the pelvis or below, in other words, if they're immobilized, if they've had a stroke or multiple trauma or spinal cord injury, they score 5. These patients must receive both pharmaceutical management, and they must also receive graduated compression stockings into pneumatic compression. So for those patients, you don't even need to go, it's the clinical setting that will determine it. So if we look at patient factors, our 61-year-old patient is over 60, so he gets 2. I know it's your birthday tomorrow. What are you turning tomorrow?
My last year in the 40s.
Okay, so, but you still score 1 because you're aged between, you're over 41. So you get 1 for that. You get 3 for a history of DVT and PE.
Yeah.
And I think we should multiply that by 4, so it's probably 12.
For everyone.
15, but you've had 5. And then if we go through this tick list, you'd see that pretty quickly we should be anticoagulating you just based on your age and your medical history. And I'll go through what we do with the various scores. There's your oral contraceptives or hormone replacement therapy, swollen legs. And the other thing that's worth mentioning is patients who have cancer. If you've got a 61-year-old patient about to go for a knee replacement, it's probably worth doing, and you can do this with point of care, a fecal occult blood and a PSA with this man. Because if he's got a high PSA, he's going to, and he's having elective surgery, you kind of want to sort out thrombotic factors first. And your protein C or S deficiency, factor 5 Leiden, you scored 3 on factor 5 Leiden, you score 1 on your age, and you score at least 3 on your history. So you're sitting at 7 before you've even had any surgical procedure done. So I think we really do underestimate patients, or the number of things that can lead to DVT. So the next thing is, well, so we've made a diagnosis. What are we actually going to do about it? So step 3 is you look at your scores. You're scoring at 5 or more. So is our 61-year-old going for a knee replacement. You need graduated compression stockings and intimate pneumatic compression. And then you need either low molecular weight heparin, or you need oral anticoagulation. And if step 5 is to choose, and what we've got in Africa is the graduated compression stockings, which DMD currently supply in Zimbabwe. And we've got pneumatic compression, so you'd need both of those if you were going for anything surgical. And then the question comes in is, what's better, low molecular weight heparin or oral anticoagulants? So low molecular weight heparin, I think, is excellent in the early stages post-surgery because it's reversible with post-knee. So the last thing you want in a multiple trauma unit is to make them bleed post-operatively into the abdomen, for example. However, after a few days, I'm sure you would agree. I mean, I know personally, if somebody sent me home after elective surgery, I'd probably last about a week on Clexane or enoxaparin injections before I'd kind of be going, do I have to jab myself again? So we're also going to discuss in this the rationale behind starting with low molecular weight heparin and then progressing on to oral anticoagulation. Warfarin, I haven't really gone into. It is very commonly used here, but we also know how many things it interacts with. You have to watch your diet very carefully. You've got to watch what other drugs you're taking very carefully. Sometimes the INR just goes off all by itself, and you've got to adjust. So it involves a blood test once a month. There's a lot of things that patients find inconvenient.
It's difficult to remain compliant as a patient on warfarin, I have to say. It's even for me who know the importance, it's compliance is difficult.
And you travel a lot.
Yeah.
So do you take it the same time of day every day?
I try most of the time.
Okay. So we'll be doing your INR in the next 24 hours. But basically what a lot of people don't realize is if you've got one risk factor, which is just being over the age of 40, you should have early ambulation, which we will discuss. But if you've got 2 risk factors, you need to be on low molecular weight heparin. And if you look at the actual personal risk factors, there are a lot of risk factors here. Pregnancy or postpartum, you're going to score 1. And if you're carrying any excess weight and you've delivered, you're scoring 2. You should actually be anticoagulating post-op. So the big thing that we're very big on with Avacare is what is affordable as well as what is available, because it's all very well to come up with some of these things, but if you can't get it, there's a snag. So I think the things that we would say are easily available and affordable here are early ambulation. How do you get your patient moving? Big bulky dressings don't help. I'm sure, having been through 2 Caesars, you know what it feels like to have a great big dressing in your lower abdomen. It's not very comfortable at all. And then we've got graduated compression stockings. Again, putting that onto an existing DVT or after a knee replacement is not going to be very comfortable for a patient. Intermittent pneumatic compression will go through. Low molecular weight heparin and oral anticoagulant, which is warfarin, and the direct oral anticoagulants. So how can we help? One of the things we're going to do on Thursday is to go and demonstrate prevention, which is a dressing that lasts for 3 to 5 days. You don't need to wash the wound. It minimizes infection. Infection will lead to a hypercoagulable stage in the child's triad. So we don't want infection in the wound, but we also, it's antimicrobial resistance week, so we don't want to be pumping every single knee replacement and hip replacement full of antibiotics. So inhibiting mobilization, a great big bulky bandage, if you've had a knee replacement, is very easy to move on. So there's a whole range of organic polymers out now, and these do two things. They prevent infections. So if you've got a pin that's just been inserted orthopedically, in Namibia, they are getting zero pin rate infections, compared to 23% in patients who have a pin put in, even in patients who have antibiotics because of antimicrobial resistance in the hospital. So this is looking very, very promising as one of the products. We've only got it here as samples at the moment, but by next year we should have it in, it's SAPRA approved and it's MCAS approved. So I think it's an important option. The graduated compression stockings that you're familiar with, putting those on can't be very easy if you're in pain, but nonetheless, if you're flying, do you fly with compression stockings?
I do. That's probably the most compliant I am, because they really help reduce the swelling, and it almost gives me a feeling of comfort, because I almost always have a bit of a heavy leg feeling. I do know that I don't have enough sufficient drainage in my left leg, especially. I think it is the venous valves are so damaged by now after the 5 DVTs that I am a big fan of the stockings. I wear them when I travel, especially long haul. It compresses, it reduces swelling, and it almost gives a level of comfort.
And I like the fact that they start with high pressure and then they move up as you go up the leg. Then if we look at what you can do, you're very familiar with low molecular weight heparin.
Yeah, that looks familiar.
Rivaroxaban is now very affordable. Certainly in Zim, I think there's 6 different brands of it. And I think that it goes for between $30 and $40 a month at a pharmacy. So we'll look at the pharmacoeconomics in a minute. The intermittent pneumatic stockings, what's certainly happening with the hospitals is that the machine is actually given free of charge to the hospital, and then the disposables are given to the patient. The interesting thing about this machine, and Tina's in the room and she can correct me if I'm wrong, but the machine's quite smart. It actually works out when blood is re-entered, and it sets itself so that for each individual patient, it will blow up when the circulation is restored to the foot. So obviously you don't want to cut off the circulation to the foot. So it's a smart machine, and it will set itself, and once it's got to know you, it will blow up and reduce depending on what your circulation is. Am I correct?
Yes, it's a vascular refill detection. So
vascular refill detection.
There we go. We've got a new word for today. So, I mean, I think that's incredibly clever, and I think it's a great product. So we talk about the options of injectable versus oral. Well, why not both? Okay, we want the injectables early because we can reverse them, but we need the orals probably for compliance. And certainly in 2020, 2021, when we had a lot of people who were very hypercoagulable, we would know we would be discharging the patient to home. So we would give a single injection of low molecular weight heparin, usually 80 milligram dose, and then at the same time start them on an oral anticoagulant, which takes about 12 hours to kick in. So if we go into the pharmacoeconomics of it, and these slides I would like to thank Avocare for. So the pharmacoeconomics, first of all, let's look at our patient who's having a knee replacement. If we look at the US FDA approved indications, there's treatment of deep vein thrombosis. In your case, prevention of recurrent deep vein thrombosis. In the patient who's in this presentation, it's prevention of DVT if you're having knee or hip replacement surgery, and prevention of venous thromboembolism in an acutely ill medical patient. I personally, my father has a history of cardiac disease, he's had a bypass. Certainly, in retrospect, I don't know if they did thromboembolize him, but given that he has quite a high likelihood of clotting off his coronary arteries as well, you're getting a double positive there. You're not going to get a clotting off of the coronaries, and you're also not going to get clotting of the venous system. And my dad is also in AF and has been since 1998. So it's prevention of stroke. And for him, I don't think he's particularly worried about sort of dying suddenly, but he would never ever cope if he was disabled by a stroke. He's still working at 82, retires about once a month and then goes back. So going back to the cost of rivaroxaban, the 10 milligram film-coated tablets, which are used for prevention, are $1.70 a day. If we look at river therapy, if you're using prevention for a month, it's going to cost $52. Whereas if you're using Clexane specifically, which most people know, they don't know the word enoxaparin, you're looking at $15 a day. So if we look at in treatment of DVT, Clexane is double the cost of river, but in prevention or in hip replacement, it's 10 times the cost, because we obviously use a lower dose of rivaroxaban for prevention. So they also go through the fact that the product information says that you shouldn't use low molecular weight heparin for more than 14 days. Not many people read the product information, as we know. And training is required for outpatients on long-term injectable therapy for self-administration. Most people that I know who have been on injectable low molecular weight heparin are very bruised on about day 4 or day 5. They start bleeding under the skin. There's a high risk of error when you're injecting, and a patient who can't self-administer has to go to the clinic daily. And again, with many of these patients, if they have any cognitive impairment, you're going to have a carer administering it. It's just not going to work. So as we've mentioned, pain, bruising, swelling, itching, or rash at the injection site. So we also have a product called Lomo, which is $7 a dose. So that's half the price of Clexane. And rivaroxaban is $1.70 a tablet, which works out in a month at about a third of the price of Xarelto. So in terms of affordability, certainly in this country, we have many patients that are not on medical aid. And I'm not sure what it's like with your medical aid, but you pay shortfalls.
Yeah, I think the only positive about warfarin is that it's affordable, but it is a pain to be compliant and go for all the INR tests. But yeah, if your medical savings, if you are lucky enough, the 30% that does have access to your medical aid, if your medical aid savings fund is depleted, it's depleted. So in all, you can maybe get it onto your chronic, but it's always the shortfalls. There's always short. And then 70% of the population does not have access to medical aid. So it's a similar situation.
Well, you're a lot better than us, because over 95% of our population do not have access to medical aid. And though probably 500,000 out of 15 million have full cover, people on other medical aids will pay shortfalls on certain medications. So we need to be aware that compliance can sometimes be financially driven. So in terms of affordability and common sense, should we be using low molecular weight heparin for 3 to 5 days in hospital? And then when the patient is discharged, we move to either warfarin, but you've got to assess whether the patient's going to be going for INRs. And certainly I have a patient we've switched from warfarin to rivaroxaban. She was paying 70 US a month for a consult and a INR every month. So 70 US total for that. So that turns out to become, it wasn't sustainable. So she was switched to rivaroxaban. So if we look at the pros and cons, I'm not sure. I mean, I know you've spent a lot of time in theatre, but my most vivid memory of a GIT bleed was a patient who had esophageal varices and ruptured them, and there's absolutely nothing you can do. You cannot compress it. So I think anybody who's worked in casualties, who's seen a massive gastrointestinal bleed, is rather afraid of them because doctors don't like to be completely out of control.
Yeah.
So the first thing people will say is there's no reversal agent for rivaroxaban, whereas there is one for enoxaparin, which is a deterrent. But for me personally, if I know the patient has no occult blood in the stool, and if I know that the patient has is Helicobacter negative, which would be 70% of our population Helicobacter positive here. So we've got a lot of interest from people who want to trial Helicobacter drugs because in Australia they don't have anybody left who's Helicobacter positive. So if I was talking about one of my patients who's going for a knee replacement, probably about a month before the replacement, I'd want to be checking for Helicobacter if they're going to be anticoagulated so that I can treat them before they actually go to hospital if they come up positive.
Good question on that. So if like in my case, I have to be anticoagulated the way I understand it for the rest of my life. So the risk factors now are different because my risk is bleeding if there's an MVA or something like that. So when does that outweigh the risk of a non-reversible like Rivard for me versus something with often you can just give a vitamin K injection?
I think it's a very individualized decision, and it depends a lot. My father is a classic example. He is actually not anticoagulated, despite the fact that if we do his scoring, he's over 75.
And
he's in atrial fibrillation. No, well, it's scoring for atrial fibrillation.
Okay.
I think it's called the Wells criteria. But if you are over 75, you get a point. If no, that's over its age. It is whether or not you've ever had a stroke. I think you get 2 points on it. And he's diabetic, which is one of them. Congestive heart failure is another risk factor. But he scores over 2 just by virtue of his age and the fact that he's diabetic. And as a result, he should be anticoagulated. However, he lives 2 hours away from the nearest hospital that could give blood transfusion. And he is still very spry. He climbs up. Probability of him injuring himself is high. So we have elected to not anticoagulate him, but he also lives a very healthy lifestyle. He takes aspirin and various other things that he does. I think it's a very individualized decision. You have to discuss what someone's doing. You know, there are some people that are very low risk of injury, and then there are some people who are quite high risk of injury. So we need to look, how can we minimize the risk of a GI bleed? So we can predict that if you go and drive in certain areas at high speed, you are much more, if you're a motorcycle racer, you're going to elect to be on warfarin, whereas if you are in a sedentary office position and you live over the road, you probably would go with direct oral anticoagulation. But the big fear of GPs is the risk of a GI. So how do we lower the risk of that? At GP level, in the GP surgery, a patient can bring in a stool sample for fecal occult blood, and that same stool sample can be you can look for Helicobacter in the stool, but you're looking for the antigen, not the antibody. Now, antibody testing is very common in Zim. The problem is if you are IgG positive, all it shows is that you've had Helicobacter in the past. If you've never been treated for it, you've probably still got it. But what we're actually looking for is the antigen in the stool. And if you've pre-warned your patient, you see them for their knee replacement, and then you say, I need to see you in a week. We're going to do some bloods on you, full blood count, the normal pre-op bloods. And you say at the same time, because also if they're anemic, they may have a colonic cancer. So there's other reasons apart from just being fit for surgery. And then you tell them the next time to bring in the stool sample, and probably for about less than $10, you can run both of these tests and you've got an answer within 15 minutes. This could also be done on admission. Now, here's your friend, the U image. And obviously, early detection of a clot. You were telling me before the difference between a below knee clot and an above knee clot. And you would know.
Yeah, so it turns out that below the knee is kind of disregarded from what I've seen with sonographers and vascular surgeons, because these are not the dangerous clots. They don't embolize easily. But these are the ones that your patient will most likely complain about because they are very painful. Those are the ones you feel. You can barely touch your skin because it's so sensitive and it's red and swollen or discolored. But above the knee, so upper leg and up, are not necessarily the ones you feel that as such a painful clot. But these are the dangerous ones. These are the ones that caused my near catastrophic event. So definitely the tip would be to not discount the smallest patient, the burning sensation in the calf that you would feel even if you have an above the knee clot. So there's definitely that little distinction, but I think all clots should be treated with the same severity, because if there's below the knee, there could be another one above the knee, you don't know. So
what would be the easiest thing for you to teach a nurse or somebody who's seeing the patient daily on the ward? Would it be easier to Doppler on the calf, or would it be easier to do sort of the saphenous vein?
I would say femoral greater saph is probably the easiest, because I think, well, popliteal and femoral, I would actually say
would be easier.
Because it's the bigger ones. It's easy to see, it's easy to find, and these are the ones that you want to know that do not have clots in them.
And at the orthopedic conference, they mentioned that some patients wait 5 to 7 days for a hip replacement, so they are completely immobilized for 5 to 7 days. So it would be good to be able to scan them. And again, they're going for surgery, so people are not going to want to anticoagulate them before surgery. Where low molecular weight heparin is good is that it's gone in 12 to 24 hours, so you can stop it. And
I think another note on that also is, just again from personal experience, when you look for the usual suspects, the swollen leg, the discoloration of skin, once you at that point, the clot's already well matured. And because I tracked the progression with the last one so carefully, I could see how that clot was already properly there before I actually showed the symptoms that you would clinically see, I think, days later, with the red skin, the discoloring of the skin, and the swollen leg. Because the swelling comes and goes. It's not a permanent state of swelling. Sometimes it's better, some days it's better than others, even though this clot thickens.
It's actually quite good.
Thank you.
But the thing that I think is also important, and I've only just come to understand this yet, is that the thing about the U image is it has a curvilinear probe, which most ultrasound machines do, the portable ultrasounds. But the fact that in the same device you've got a linear probe, and in the same device you have Doppler. So talk us through what you would do if you turn the Doppler on.
Yeah, that's definitely the thing. So first you will do a 2D approach, where you will use the curved or the linear, depending on the penetration you need for your patient's type, for the body type, how much, how big the leg is, how deep the vessel is. And you will do a 2D look for the for the clots. And then to confirm or deny, you will obviously press it to see if the vessel collapses, because that vessel will not collapse if there's a DVT. But again, in my case, the one time the femoral did collapse was the DVT was just a little bit higher into the iliac. And that was immediate dismissal of my case, which is not accurate. But so 2D is very important in all the vessels. But then the other thing is to put color Doppler on, because color will clearly show that there's flow. But because venous flow is low velocity, you have to accentuate it by just compressing the calf, and you will see the flux of color Doppler through the veins. And then your last option or method is to place a pulsed wave Doppler in the vessel and do the same compression of the calf, and you will clearly see and hear the pulsed wave Doppler accentuating of that reflux. So you know there's blood going through. If it's dead, there's no blood going through, so you have that.
Okay. And you've been training midwives who are very scared of this device before.
Yes.
Do you think you could train midwives to use this?
Oh, absolutely. I'm increasingly becoming an advocate for point-of-care ultrasound and the role it plays in screening patients. Midwives have stethoscopes, the same as an obstetrician does. It doesn't mean she's doing the same work that an obstetrician does. If she does a limited obstetric screen, handheld focused ultrasound devices and extension of that skill, which you would normally listen with an otoscope or feeling, it's a visual stethoscope in many cases. So if limited obstetric screening is clearly demonstrated to be successful, there's no reason for it to expand into other areas of a screening and a primary and referral care process. And DVT, if your prevalence is that high, there's no reason why they shouldn't go.
And again, I think if you would probably not have got a full-blown DVT in both your pregnancies, if it was as regular as checking the fetal heart was a point-of-care ultrasound in the lower extremities.
Yeah.
So I think I've been asked a couple of questions by people, what makes this probe different? And I think that it has 3 modalities in one device, plus it's very portable.
And it's not tethered, so there's no cable. The Wi-Fi connection is also very valuable for if you're moving from a carotid all the way to a lower limb. There's no cable that holds you back to a device or a screen. So that's a very valuable.
And you might be looking at lung ultrasound on the right ventricle if you think the patient shot a PE.
Exactly.
Okay. So I think the message is that POCUS DVT, looking for DVT with POCUS, definitely has been shown to save lives. So going back to what we were saying, you can actually use graduated compression stockings as well as intermittent pneumatic compression. And what was Tina's word? Vascular refill detection. So you will detect if your TED stockings are insufficient and you actually need to put more pressure on to get the blood back towards the heart. So again, we go back to alternatives to Xarelto and to Clexane. And really what the message is to primary care providers who are referring patients for surgery or who are referring very sick medical cases who are bedridden, you want to ambulate someone within 24 hours of admission if you can. If you haven't fixed their hip, you can't ambulate them. But obviously, you really want to do that. But the thrombosis risk assessment should probably be done pre-admission, and probably 2 to 4 weeks pre-admission for elective surgery. But if you've got an emergency admission, you want to administer within 24 hours. You identify the clinical setting, you identify risk factors associated with the patient. If you have one factor, and I think it would be quite hard at my age to only, in fact, I can't get one risk factor. But then you would only early ambulate. If it's 2 risk factors, you can use either the manual, the intermittent pneumatic compression, or low molecular weight heparin. When you're at 3 to 4 risk factors, you need the devices, IPC, and low molecular weight heparin. And 3 is not a very high score. I think you've got 3 in the first, first column.
Plus over 5.
So again, this is what's available in the region. I'm not going to go through that. So in the ideal world, someone heading for a knee replacement, or someone who is like you, who's already anticoagulated, we need to do fecal occult blood testing. With this, you can also do Helicobacter testing on the stool. If you're going to do a finger prick, you can check the PSA. If you're suspecting cancer, and other tumor markers can also be done at point of care. And you need a risk calculation 2 weeks before, so you've got time to treat Helicobacter. Organic polymer dressing post-operatively, so you avoid antibiotics and antimicrobial resistance, and get the patient up and moving. You need both the TED or the graduate compression stockings and intermittent pneumatic compression. And POCUS looking for DVT should probably be done daily as part of routine observations. It's probably more important than checking blood pressure and pulse and the standard observations that are done. Low molecular heparin for 2 to 5 days and discharge on liver oxygen. If that had been done in your pregnancies, you might not have had quite as many events as you had.
Exactly. I mean, barring the surgery in my case, but just as a consult to do the screening would have been very helpful. I'm convinced it would have been seen much earlier before I presented with the severe symptoms at that stage. Okay.
So with that, I think we can end it. We can open the floor to any questions. Tina is around, although she's not on her screen. Anything that you'd like to add or you'd like to ask? Or have we covered it?
Okay, thank you everybody for listening to that. And
good afternoon, Doc. Excuse me.
Yep.
Excuse me. I had thank you for the presentation. It was well put on. Now I had a question on what can I say on the treatment of DVT on a lactating mother or during the pregnancy. As she has mentioned, she's a G2. Yes, that was my question. Thank you very much.
So you're asking about what is safe during pregnancy and lactation?
Oh yes. What would be one of the things that you would have to pay much more mind to? And I love the point towards the end. You did mention that we should really look out for DVT during the triage moment. So now I'm wondering with pregnancy, what would be one of the things that we should look out for?
So in pregnancy, I think you've got to look for the symptoms of DVT, and you can do the scanning as well. But in terms of the medication that's involved, at the moment, low molecular weight heparin is recommended as the treatment of choice in pregnancy, partly because there's insufficient data probably on the direct oral anticoagulants. But Annerie, you would have experienced this. You had low molecular weight heparin in pregnancy because of that's the ideal treatment in a pregnant mother. Is that correct?
Yes, indeed. It was the Clexane injections from as soon as I was diagnosed up until 6 weeks postpartum, and then eventually the gradual move over to warfarin again. Unfortunately, as we all know, the Clexane injections are very expensive.
Yeah. So it becomes quite difficult in someone who's financially strapped. And in lactation, as far as I know, you can use the rivaroxaban, and I know it has been used. I think when you're talking about pregnancy, I mean, the classic comment is that if Serena Williams could get a DVT after pregnancy, you can't assume that it's, that every DVT is going to happen in a non-athletic or overweight mother. So I think it's just really raising you need to have a high index of suspicion. Very often in my experience, patients will come in with swollen ankles in late pregnancy, or one ankle more swollen than the other, and people say it's just pregnancy. If we can train people to detect DVT with a U image of point of care ultrasound, I think that we would do postnatal patients and pregnant patients an enormous service, and particularly if it could be taught to midwives, and if a device could be available in every antenatal and postnatal clinic.
Thank you very much. That was well clear put, and I will really do take it into consideration. The same way it is also considered in the orthopedic wards. Thank you very much for your time. That was all from me. Thank you very much.
Thank you for your question.
You're welcome, Doc. Thank you very much.
Has anybody else? I can't see any hands raised, and I can't see anything else in the chat.
Sure. Dr. Jackie, there's a question or comment from Herman Spies.
Okay, can you read it out to me? Because I'm scrolling at the moment and I haven't seen it yet.
Okay, the question is, are there any other alternatives for lifetime treated patients on Xarelto when patients are experiencing multiple side effects on it?
Okay, so, and that's a very important question. So at the orthopedic conference, if you really do have a lot of side effects, everything's a risk-benefit analysis at the end of the day. So one of the surgeons at the orthopedic conference, who was from Canada actually, said that low-dose aspirin can be used as an alternative to low molecular weight heparin and to rivaroxaban, or any of the DOACs, the direct oral anticoagulants. It's not as effective, but it's definitely better than doing nothing. So my suggestion, and I've also said this about another patient, so we had a patient who was switched from warfarin to rivaroxaban, and she started to get very, very heavy menstrual periods, and basically bled out to a hemoglobin of 7. And the solution was very clearly to switch her back to warfarin, on which she had very little side effects, but it was much more labor intensive because she had to have regular INRs. Now, in her case, what was done was she had a Mirena IUCD inserted, which means that she wouldn't have such heavy blood flow, and she was switched back to direct oral anticoagulation, which she tolerated well after that. So I think if you're not tolerating, if the side effects are sufficiently severe on a direct oral anticoagulant like rivaroxaban, you can try switching brands, because sometimes it's actually the excipients that are making you feel unwell. Or you can switch to warfarin, but then you have to be very disciplined with your diet, with taking other medications. And you also, you have to be aware that antibiotics, for example, will interact with it, and so will excessive green leafy vegetables. So warfarin tends to have less side effects, but you have to be disciplined and have a regular INR on warfarin. And if you can't tolerate either of those, aspirin at a dose of less than 150 milligrams a day, so 87 to 150 are the usual ranges, is an alternative option. I'm very much for patient autonomy. I'm not, as you know, in favor of a paternalistic form of medicine where doctors dictate to patients. Patients have the right to choose what medications they want. There's obviously, and we don't have time to cover it here, but I've seen Renee Bosman on the call. There are a number of herbal alternatives that are considered blood thinners, but that's an entire lecture on its own. And if you do Google it, you'll find there are a lot of herbal alternatives. So my feeling would be, in someone like Annery's case, I would be, as her caregiver, terrified of her going off warfarin or rivaroxaban. But if she chose to, the next level down would be aspirin. And if she chose to not take that, then she could try some of the herbal anticoagulants as well. I hope that answers your question.
Thank you, Dr. Jackie. It doesn't appear as though there are any more questions on the chat.
No, I haven't seen any. So I think with that, I'll move on because we're obviously getting to the end of the year. I think we've all got end of year fatigue syndrome. But as a bit of a Christmas present for those who are still lacking CME points, and also for those who are interested in integrative medicine, on the 6th of December, which is in a week's time, we will be running a 2-hour session. It will be our last session of the year. And we will be joining Silver Lab in South Africa, who will be doing a 2-hour CME session, for which you will need to, we will share the link, but you will need to, there will be questionnaires involved, which you will have to read before the session. You may have to answer during the session, and you will answer at the end of the session. But it carries 8 CME points with HPC SA and HPC NA, and it's also accredited in Mauritius. So we're very pleased to be able to offer the CME training at the end of the year, when I'm sure people who are short of CME points would love to join. And also for those who are interested in integrative medicine, I think it promises to be a fascinating session. Dr. Anton van Rensburg, who is rather famous in South Africa for much of his integrative medicine, will be running it. And we look forward to the session. It will coincide with ICASA here, but I intend to leave the ICASA session in order to join this. So next week, we hope to see you again. Obi, do you want to close us down?
Super, thank you, Dr. Jackie. Just as an expansion to that is the details and the link to that session we'll add into the WhatsApp group. If one can refer to the chat on this session, there are links to the WhatsApp group together with the link to pre-register for the session next week. So please look out for that. Look out for those links.
And Obi, we must make it very clear that it's starting half an hour earlier. It's starting at 6.
Absolutely, sure. Thank you. Thank you for that reminder, Dr. Jackie. So the session is starting at 6 p.m. and it's intended to run for 2 hours. So that's a slight deviation from these sessions that resume at 6:30, and I intended to run for an hour. So the next session will start at 6 o'clock and run for 2 hours. So please be on the alert for that. And also please note that you will not get access to the session unless you pre-register. There is a limitation of 500 recipients for that session. So the sooner you're able to pre-register, the better. Okay.
Great. And with that, I think we should leave the link open for registration for another 5 minutes. And then I wish everybody a happy Wednesday.
Absolutely.
I see there's a note from, I think, Dr. Kum, that he has a comment.
Oh,